Welcome to this lecture on anuria and obstructive renal failure. I am your instructor, Dr.Junaid. Today we will discuss the mechanisms, causes, diagnostic approach, and management principles of these critical urological emergencies, emphasizing their clinical importance in preventing irreversible renal damage. The goal of this session is to build a comprehensive understanding not just of what anuria is but why it happens, how to differentiate obstructive causes from others, and how to intervene effectively. How to define anuria? Anuria represents the extreme end of reduced urine output. It's a clinical sign, not a diagnosis, indicating a severe underlying pathology. When obstruction causes this, we term it as obstructive renal failure, one of the few reversible causes of acute kidney injury. What are the types of anuria? Classifying anuria helps pinpoint the level of pathology. While pre-renal and renal causes are medical, post-renal or obstructive causes are surgical emergencies requiring urgent decompression. Pathophysiology of obstructive renal failure. In obstruction, pressure builds up within the collecting system, opposing filtration at the glomerulus. Initially reversible, but sustained obstruction causes ischemic and fibrotic changes, leading to chronic renal damage. Hence, early recognition is critical. As you can clearly see in this picture, there are various causes of acute kidney injury are enlisted, like ischemia, toxic injury, and sepsis all lead to acute kidney injury by the process of inflammation, vascular injury, and tubular injury. This picture is showing the causes of acute kidney injury, like pre-renal cause due to the impaired renal blood flow, and renal cause including the injury within the kidney structures, and post-renal cause due to obstruction of the urinary outflow from the kidneys. This picture is also showing the acute kidney injury etiologies. Then what are the causes of obstructive renal failure? Obstructive anuria occurs only if both kidneys are affected, either by bilateral obstruction or by obstruction in a solitary functioning kidney. Always look for causes at both upper tracts and lower tracts. Like upper tract pathology lies within the kidneys and ureters, and lower tract injury lies within the urinary bladder, prostate gland, bladder neck, and at the level of urethra. Clinical features. The presentation varies. Painful anuria often suggests lower tract obstruction, whereas painless anuria points toward higher obstruction or neurogenic causes. Always assess for systemic signs of renal failure. A focused physical examination can provide critical clues. A palpable bladder is almost diagnostic of outflow obstruction, while renal angle tenderness suggests upper tract involvement. So always start with a bladder scan. It's a simple, quick, and tells you whether urine is accumulating. Laboratory tests quantify renal dysfunction, while imaging defines the cause and site of the obstruction. As you can see here, diagnostic workup includes, first of all, is the ultrasound KUB, kidney ureter bladder. Then we can attempt the catheterization as diagnostic and therapeutic approach. Then laboratory tests include renal function tests, then urine analysis. Then imaging studies include ultrasound as mentioned previously, then CT scan of the kidney ureter bladder, which is non-contrast, enhanced CT scan, which identifies level and cause of obstruction, or we can use intravenous urography, which was used formerly. What are the emergency management steps? Stepwise approach includes around two goals. First of all, stabilizing the patient and relieving obstruction. Bladder catheterization often resolves the issue if it's a lower tract cause. If blockage is higher, proceed to percutaneous nephrostomy tube placement, which is often life-saving. What is post-obstructive diuresis? After decompression, kidneys may excrete large volumes of dilute urine, which is a physiologic response to previous fluid overload. Uncontrolled diuresis can cause severe dehydration, so close monitoring is essential. Definitive management. Once the emergency is controlled, the focus shifts to definitive correction of the cause. Renal recovery depends on duration and severity of obstruction. Early intervention offers the best prognosis. Complications emphasize the importance of early recognition. Delayed decompression may convert a reversible injury into permanent renal damage. So, as you can see, there are various complications like acute kidney injury, post-obstructive diuresis, infections in the form of pyonephrosis, urosepsis, electrolyte disturbances, and chronic renal failure if this reversible injury gets prolonged. The outcome is time dependent. Prompt decompression usually restores renal function, while delay leads to cortical atrophy and fibrosis. Hence, in obstruction, time equals kidney. What are the key takeaways from today's lecture? To summarize, not all anuria is renal failure and not all renal failure is irreversible. The key lies in recognizing obstruction early and intervening promptly. So always remember this principle, because missing an obstructive cause can cost a patient their kidneys, while timely drainage can restore function completely. So anuria in an adult is obstruction until proven otherwise. So that's it from today's lecture. We will we will see you in upcoming lectures. Until that time, good luck to all of you.